So that talk focused around the use of circulating tumor DNA as a marker for minimal residual disease. And I used the model of colorectal cancer to highlight the potential for ctDNA as a marker for MRD or minimal residual disease. What we know today is that about 40 to 50% of patients with stage 3 colon cancer are cured by surgery alone and may not need adjuvant chemotherapy. Now, we do not have a good way to identify patients who are at a higher risk of developing recurrence after surgery. So we end up giving everybody chemotherapy in the hopes of helping the patients who may be at a risk of recurrence. With that approach, there are two major drawbacks. Firstly, we are exposing everybody to the side effects of chemotherapy. And secondly, the chemotherapy that we have currently does not help everybody who's at a risk of recurrence. What we know is that it probably prevents recurrence in about maybe 25% of the patients who are at a risk of developing recurrence. So what we truly need is a good biomarker that could help identify the patients who are at the highest risk of recurrence. ctDNA fills this void, and what we know is that patients post-surgery who are positive for ctDNA, that is positive for minimal residual disease, are at a much higher risk of recurrence than those who are ctDNA negative. What we also know is that ctDNA as a biomarker is much more powerful in terms of determining prognosis as compared to what we use currently, that is the TNNM staging. So how do we translate this information into clinical practice? So the idea would be that you check for ctDNA post-surgery, and in patients who are ctDNA positive, you deliver adjuvant chemotherapy and potentially even escalate adjuvant chemotherapy to improve outcomes in these patients. And in patients who are ctDNA negative, you think about de-escalating therapy or even holding off on chemotherapy and thinking about checking ctDNA serially and starting chemotherapy if and when patients turn positive. And this is being evaluated in prospective clinical trials. For instance, there are several clinical trials ongoing in stage 2 colon cancer. And in stage 2 colon cancer, often we tend to not do adjuvant chemotherapy or do an attenuated version of chemotherapy. So what a lot of these clinical trials are doing is that you check for ctDNA in stage 2 colon cancer patients post-surgery and ask the question, in the patients who are ctDNA positive, can we escalate chemotherapy to improve outcomes in these patients? A typical example would be the ongoing COBRA trial in North America, where patients who are low-risk stage 2 colon cancer, who are deemed low risk by their treating physicians and are deemed not to require adjuvant chemotherapy, are randomized to standard of care where they undergo surveillance versus ctDNA-directed therapy. So you check for ctDNA in these patients, and those who are ctDNA positive get adjuvant chemotherapy, and those who are ctDNA negative undergo surveillance. In stage 3 colon cancer, where everybody is recommended to get adjuvant chemotherapy currently based on guidelines, ongoing trials are trying to ask the question, based on ctDNA status post-surgery, can we escalate or de-escalate chemotherapy? A good example for that would be the recently approved GI-008 or Circulate US clinical trial. Enrolls patients with low-risk stage 3 colon cancer, so that is T1 through 3 and 1 stage 3 colon cancer patients. And these patients after surgery are evaluated with a ctDNA assay to see whether they have MRD or not. And patients who are ctDNA negative will be randomized to immediate chemotherapy versus serial ctDNA evaluation with a plan to start adjuvant chemotherapy if and when they turn ctDNA positive. In patients who are ctDNA positive immediately after surgery, so both groups would be combined. That is, patients who are ctDNA positive immediately after surgery, and then ctDNA and patients who are ctDNA negative initially, but then turn ctDNA positive. So these would be clubbed, and these patients would be randomized to current standard of care of 5-FU or capecitabine with oxaliplatin versus adding on irinotecan to 5-FU and oxaliplatin to see which regimen would be effective. So we're trying to intensify chemotherapy in these patients. Now, so far we've talked about the use of ctDNA in patients who have had surgery and we're trying to make decisions about their standard of care adjuvant chemotherapy. Now, how about patients who completed their standard of care adjuvant chemotherapy and are still ctDNA positive after completion of that therapy? That is truly where I think we need to focus our efforts, and that would provide us the best bang for the buck and really revolutionize how we develop drugs in the adjuvant setting. For instance, the traditional approach for developing drugs in the space would be to do a large phase 3 clinical trial where you require hundreds or thousands of patients, and these patients also need to be followed for a long time to get the reading of a disease-free survival as the primary endpoint. So by using ctDNA, I think we could revolutionize this approach by taking small cohorts of patients who are ctDNA positive and then testing novel drugs with a primary endpoint of ctDNA clearance. And this would read out very quickly, and these patients and these cohorts would be maybe even 15, 20 patients, leveraging the fact that almost every patient who's ctDNA positive would eventually develop a recurrence. And the concepts and the drugs that are most promising could then be taken forward to further development. So that truly is the potential for ctDNA as a marker for MRD immediately after surgery and also after completion of adjuvant chemotherapy.